Good afternoon. Today I'll be presenting a case which had come to our emergency department. My name is Joshua S. Chacko from Father Muller Medical College. I'm a final year MBBS student. The patient had presented to the emergency department of Father Muller Medical College at 5 a.m. in the morning. He was a 64-year-old man who was a farmer hailing from Mangalore, Bajpe. He was unmarried and a Hindu. His chief complaints were generalized weakness in 3 days, retrosternal pain radiating to back since 5 days. History of present illness: generalized weakness which had started 3 days before the entrance to emergency department at 5 a.m. He complained of epigastric pain that was radiating to the back with no relation to feeding and intermittent burning retrosternal chest pain. He had a clenched fist to his chest. He also had nausea, vomiting, and cold sweating. The vomit was eaten food and without bile and blood. There was no reduction of pain on bending forward. There was no fever, melena, or dyspnea. Past history was suggestive of hypertension, ischemic heart disease, and CCU admission, which happened 2 years before. Diabetes mellitus was negative. No history suggestive of TB, measles, jaundice, trauma, or injury. The personal history: sleep was deprived, bowel and bladder movements were normal. No smoking, no alcohol consumption, no substance abuse was seen. Family history: his father had died due to myocardial infarction. On general physical examination, the patient was conscious and well oriented to time, place, and person. Pulse rate was 110 beats per minute, normal rhythm and normal in character, and blood vessels were palpable on both sides. Blood pressure was 90 by 60 mm of Hg, supine position and on both arms. Respiratory rates were 16 breaths per minute. The type of respiration was thoraco-abdominal. Temperature was 37 degrees centigrade. Axillary oxygen saturation was 92%. Pallor was positive. Clubbing was positive. Icterus, cyanosis, and lymphadenopathy edema was negative. Cold sweats were present. Inspection: it was conducted in a well-lit room, exposed from below neck till pubic symphysis. Examination of neck veins, not engorged. There were no engorgement of neck veins. Inside the precordium shape, there was no deformity, no pulsations or engorged veins, no polythelia, no scar marks. Outside the precordium, there was no pulsation seen again. On inspection of the back, we can see there was no scoliosis or kyphosis or gibbous or drooping of the shoulder or winging of the scapula were absent. No midline sternotomy scar suggesting coronary artery bypass surgeries. Left submammary scar for mitral valvotomy and infraclavicular scar for implantation of pacemaker were absent, which suggests that there were no previous surgeries or any kind of medical intervention seen in this patient. The palpation: apex beat was palpable at the left fifth intercostal space. There is no presence of thrills. Auscultation: cardiac rate increased. S1 and S2 were detected with no pathological sounds or murmurs. Other systems: respiratory system was normal with normal vascular breath sounds. Abdomen: there was mild epigastric tenderness present. Guarding and distension were absent. Summary: a 64-year-old man who was a farmer, Hindu and unmarried, hailing from Bajpe, Mangalore, came with the chief complaint of generalized body weakness for 3 days with intermittent retrosternal chest pain and epigastric pains that was radiating to back and was associated with vomiting, cold sweats. He also has a clenched fist to his chest. He has past history of ischemic heart disease with CCU admission and hypertension. On physical examination, his BP was 90 by 60 mm of Hg, oxygen saturation of 92%. He has mild epigastric tenderness. The differentials which can be seen here, which I thought of, was acute coronary syndrome, aortic dissection, acute pancreatitis, peptic ulcer perforations, bowel perforations, and the provincial diagnosis is it is a case of generalized weakness and retrosternal chest pain radiating to the back in a 64-year-old farmer with the possibility of myocardial infarction due to coronary heart disease or acute coronary syndrome. So it's not aortic dissection because in aortic dissection we can see a tearing kind of pain and it is more severe and doesn't radiate to the back. Whereas in myocardial infarction, I'm suggesting a provisional diagnosis of myocardial infarction because it shows a radiation towards his back and this cold sweats which is present and the presence of the clenched fist which he is having towards his hand and and other differential diagnoses can be ruled out. Acute pancreatitis can be ruled out because there's no relief on bending forward, and peptic ulcer perforations can be again ruled out. There's no bleeding from the mouth, or there's no hemoptysis, there's no hematochezia, and there's no other upper gastrointestinal pathology which shows there's no other symptoms which shows the gastrointestinal pathologies. Bowel perforations also it cannot be bowel perforations because there's no gastrointestinal symptoms like melena, hematochezia, or any other abdominal pain, or nothing as of that is seen. And there's no change on eating food in the patient. So other diseases, other DDs like GERD, esophagitis can be ruled out. And even it's not peptic ulcers because, as we know, peptic ulcers there'll be a change before food and after food, but there's no relievement seen in this patient. And this patient's past history is also suggestive of myocardial infarction because he was admitted to the ischemic heart disease ward before 2 years. So all these state that this patient mostly has myocardial infarction, which can be due to acute coronary syndrome. Thank you.